Okay, we're going to go over Chapter 7 in your Fundamentals book, which is on documentation of nursing care. Some of the concepts that we're going to talk about are 3 purposes of documentation, correlating the nursing process with documentation, confidentiality, 5 main methods of written documentation, and correctly making entry on a daily flow sheet. So why do we document? You know, in nursing, we say if we don't document it, it wasn't done. We document everything we do. Again, if you don't document it, it's not done. Every person that provides care must add that written documentation to the patient's chart. Insurance companies really rely on this documentation because they look at it to determine if how long the patient was in the hospital or in a rehab facility, and they look at that information to determine, was that correct? Did maybe the person stay too long? They look to see what kind of procedures were done, any diagnosis, and it helps them calculate their charges to reimburse or to pay the hospital. Excuse me. Even supplies that we use is documented. When you go into like the supply room at the hospital and you get supplies for the patient, you get, they may need a urinal, or they may need, even just like a needle to give them an injection. We actually have we have to basically, I don't know what it is. It's a little handheld thing, and then you tap like the patient's room number, and then you tap the the barcode for that supply. So it actually goes into their chart that's those supplies were used. Of course, the patient and or the insurance company is going to be charged for them, and that's the main reason. But it also does show that for example, if you say, oh, this patient was getting, IV fluids, but yet there's no sign of, there wasn't any IV fluids checked out, there wasn't any tubing checked out, then it would make somebody go, yeah, did they really get IV fluid, or are you just saying that? So it's basically, it's a written record of the history, treatment, care, and response of the patient. Again, guide for reimbursement. It shows evidence of care, shows the use of the nursing process, which we use extensively, and it provides data for any quality assurance studies. It is a legal record. It can be used in court, and actually, unfortunately, it is used in court quite often. It has observations by the nurse about the patient's condition, care, and treatment delivered. If the patient even refuses things, patient refused medication, patient refused a bath, it should be documented in the record. And of course, it shows the progress towards the outcome. There's standard areas of assessment that's on flow sheets, and typically we add notes if any abnormality exists. Any evaluation, we add that in. It contains all the data about their stay in a facility. Again, whether that facility, it could even be, in long-term care. Long-term care, the documentation is a little bit, they don't necessarily document everything that happens every day, but all meds that are given are documented. Baths are documented. Any physician visits are documented. But in a acute care facility or a rehab facility, everything is very much so, very documented. Everything that they go throughout the day. The only people that can look at the patient's chart are the healthcare professionals that are involved. If you work in a hospital and you find out that your neighbor is coming into the emergency room, or they were admitted to a different floor, you cannot legally look at that patient's chart. That's a HIPAA violation. You can only look at the chart of patients that you are assigned to. You cannot, you can't look at it, and you certainly don't discuss any patient information with someone that's not directly involved with that patient. Those are HIPAA violations, and you are subjected to get fired, and that would be the best case scenario, because you can also be charged, I think it's like up to $20,000 per occurrence. So just don't do it. Don't do it. Different types of charting. There's some that are called source-oriented, there's problem-oriented, there's focus charting, charting by exception, computer-assisted charting, case management charting, all different types. And each facility does something, sometimes they do things a little different. So source-oriented, that is organized according to the source of information. So basically, the nurses would have their charting, the physicians would have their charting, the dietitians, so everybody would have their own assessment findings. And it's documentation in chronologic order. The information is chronologic order, which is awesome. It does document the patient's baseline. That way, if there is anything happens, we can always go back and look at baseline to see if there's a change. And excuse me, it does, it goes through all steps of the nursing process. Now, the disadvantage is it documents all findings. So sometimes it's hard to find relevant information. If it documents everything, a lot of it's stuff you don't care about, so you may overlook, or it may be difficult to find what you do need to see. Extensive charting time. You spend a lot of time charting. And as I said, it discourages physicians from reading all parts of the chart. So that's very easy for them to skip vital information if there's so much stuff in there that's not necessary. Here's an example. As you can see, it goes through just pretty much the documents every little thing that went on. This is very labor intensive. This is you're going to be spending more time charting than you will be doing patient care. Problem oriented, this actually looks at the problem solving approach, and basically communicates what, when, how things are to be done in order to meet the needs of the patient. Different parts, get a database, a problem list, a plan, your progress notes, and discharge summary. Advantages: it documents care by focusing on their problem, promotes problem-solving approach, improves the continuity of care, keeps all the relevant data all in one place, and it's easy auditing of patient records. Disadvantage: you lose that chronological, so you don't have that chronological order. So it's more difficult to track trends in the patient status. If it's not in chronological order, you don't really know what happened first. Pie charting, that's problem identification, interventions, and evaluation. It follows nursing process and uses nursing diagnosis and puts the plan of care in the nursing progress notes. Here's an example of a pie charting. As you can see, they've got the P for the problem, they've got the interventions, and they have the evaluation. Okay, here's a question. Monica, a nurse in the operating room, knows that charting must be all of the following except. So charting, everything except one of these: subjective, accurate, brief, complete. Well, hopefully you all chose number one for subjective. That is the exception. So yes, you want your charting to be accurate, brief, and complete, not subjective. We do put some subjective information in. When we do that, we put it in quotation marks to show that it was something that the patient actually said, so that it is understood that that is subjective information. Focus charting. focus is when it is directed and focused on what the problem, the chief complaint of the patient. And there's 3 parts to it: data, action, response. So it is also compatible with the nursing process. It shortens the charting time, but disadvantages if the database is insufficient, things might be missed, and it doesn't really adhere to charting with the focus on the nursing diagnosis. Here's an example. Charting by exception. This is lovely. When I first worked at Baptist, they did not do charting by exception. We had to completely chart every 4 hours, every little thing, and it was so tedious. And I did spend more time charting than I did caring for my patient, and I thought that was the dumbest thing in the world. But with Baptist switching over their computer systems, they went from Cerner over to Epic, which is a different electronic health record. With that change, they began charting by exception. So what that means is when you come in and the first time you see your patient, you do a head-to-toe assessment and you do a full chart. But at that point, the rest of your charting, if nothing changes, you can it just has a little block for no change, and you only chart things that have changed. So it made a huge difference in the charting amount of time. So basically, charting by exception. This is even some facilities, if they just automatically just will put within normal limits, WNL, within normal limits, if it's okay, and then they only basically chart on things that are not normal. Some people believe WNL doesn't mean within normal limits. It means we never looked. So that's a different the different opinion on that. So advantages, again, it highlights the abnormal data and patient trends, which is good, because if I'm a provider and I'm looking at a patient's chart, that's nice because it just kind of jumps out. Hey, everything was normal, but here's the stuff that's not, and it does catch your eye. So that's pretty awesome. Definitely decreases charting time, and it eliminates duplications. So it does require detailed protocols. The last one here is really, I kind of agree with this. Nurses get so used to not charting important data that sometimes they forget. And that's true, because when we spend a lot of time charting, it is a big part of our job. We spend less time charting and more time caring for patients, which is what we should be doing. We may overlook the charting. So, everything has good and bad to it. Electronic health records, and that's pretty much so every facility. I think it came out a few years ago that if it's a facility that takes money from Medicare or Medicaid, they have to have electronic charting. I know first time I worked in a nursing home, everything was paper, and it was horrible. Because, even when the physicians would come in and see the patients, they would write orders and they would handwrite it. And then I had to try to decipher it and try to read what is it they want me to do. And it was not a good thing. So electronic is much better, much better. Let's see if they have disadvantages over here. So documentation done as interventions are performed using bedside computers. Yes, I love that, bedside computers, and you can go ahead and document right there where you're standing next to the patient. As I was leaving, I left Baptist South in February of this year, and as I was leaving, they were in the process of giving everybody what they call it. I think they called it Rover. It was Rover, but it was basically you were assigned an iPhone, and that iPhone had all the charting in it. You would carry this little iPhone around with you and literally chart, do all your patient charting right there when you're next to the patient with your iPhone. Chart everything right there. Instead of having the bedside computer, you had a little iPhone. And I thought that was the coolest thing in the world because, you know, how nice is that to always have, you know, basically your computer to do your charting. You don't have to drag a WOW around. If y'all don't know what a WOW is, it's a wireless on wheels. They used to be called COWs, which was computer on wheels, but apparently the story goes that someone overheard someone talking about their cow, and it was someone that was very overweight and thought the nurse was referring to them and became very offended. So they had to change the word from, you know, quit calling it a cow and start calling it a WOW, which was a wireless on wheels. So, you know, I've certainly drug around a little basically laptop computer around with me into patients' rooms for a long time. So the thought of not having to drag that around and having just an iPhone is really cool. What do you think the downsides are to that? So imagine if you're a patient, you don't realize that that's what they're doing, and every time they come in your room, they're pulling out their phone and doing stuff on it. You think they're texting their friend, they're texting their boyfriend, not realizing that they're actually doing the medical charting. So we were told, even during the training, because I had the training, make sure the patient is aware, this is your medical record. I'm actually using this to document about you, so that the patients didn't think you were just playing around with your phone. Here's the advantages to those computer assisted. Again, date and time is automatically recorded. Notes are legible and easy to read. Quick communication. You know what I love, because when I first was working at the hospital, we had to get a hold of the doctor. We'd have to go out to the nurse's station. We'd have to usually call a like the hospital line and say, I need to get a message to Dr. So-and-so. And then they'd say, okay, and then they would take care of that, and then you'd have to wait for a phone call to come back in from that doctor. It was a pain in the butt. They now do, it's a secured texting. So we text or even do instant messaging through the computer, and it's through an encrypted, secure, so it can't be any kind of like HIPAA violations. But now, we can just, you've got a problem with a patient, you just type it out really quick, boom, send it, and usually the physicians answer you back within seconds. It's very wonderful. Let's see. Can reduce documentation time, absolutely. Quick retrieval of records can reduce errors. Yeah, I mean, when I worked in the nursing home and had to try to decipher handwriting, I'm terrified to think about what kind of errors have been made. Disadvantages, here's a big one is the cost. It's expensive. 2, you got to train everybody. 3, this is a big one, computer downtime. Nothing's worse. You rely on your computer for everything, and then it goes down. So yeah, that part is kind of stinky. Most facilities do have a workaround. They usually have procedures and protocols that you would use if the computers go down. Case management system charting is another type of charting. Basically organizing patient care through an episode of illness. So basically you look at that particular illness and it's all charted and it's kind of clustered together. When you're charting, you need to be very specific, definite in using words and phrases. Always chart with the understanding that it may be displayed in a court of law. If a patient files a lawsuit, that chart is going to be brought into it. And so you need to think about your words, and you need to think about the way you're typing. You need to not use anything unprofessional, no opinions. If the patient is not very nice, well, we don't put it there because you just don't do that. That is especially if you have to sit up on a stand and discuss what you charted and you've put something maybe that wasn't so nice. It needs to be professional and very objective. You shouldn't use any slang words. You shouldn't use any words that could have, ambiguous meanings. Brevity. Sometimes there's certain abbreviations or symbols that particular facility you're working in, it is acceptable. So you can use that. When you always make sure that it's as brief as possible, but it's complete, that you have the whole story. You need, sometimes if it's an issue that that you feel like maybe this might be a lawsuit, maybe a patient fell and the family's all up in arms and you're going, oh God, they're going to get an attorney. You probably should you have to type everything out, because that would be an incident report. If a patient falls, it is an incident report. But when you type it all out in your note, have somebody read over it. Maybe have the charge nurse go, look, can you read this and understand what happened? Because in your mind, you know what happens. So sometimes we type things and we omit little details, but somebody else coming in and looking at it and reading it, they may be like, wait, what? And confused. So it's always a good idea to have someone else take a look at your note to make sure that it is understandable and it tells the whole story. That's kind of it. Legibility and completeness. Completeness is more important than brevity. You need to make sure it is complete. Okay, here's a question. Madison, a pediatric nurse, prefers charting by exception. So do I. She realizes all of the following are true except charting by exception was developed in 2005 by a group of nurses at St. Luke's Medical Center in Sarasota, Florida. Number 2, the goal is to decrease the lengthy narrative entries of traditional systems. Number 3, charting by exception is based on the assumption that all standards of practices are carried out. And number 4, a longhand note is written only when the standardized statement on the form is not met. So everything's true except what? Everything is true except number 1. That is not true. It was not developed in 2005. It was actually developed in the early 1970s by nurses in Wisconsin. All right, question number 3. Mrs. Smith, LPN, has just charted the following assessment on her patient. February 14th, 2008, 3 o'clock p.m., vital signs stable, voided 450 milliliters, clear straw-colored urine. Patient denies pain but appears tired. Amy Smith, LPN. Which of the following entries is incorrect? Is it the time? Is it the nurse stating an opinion? Is it no line before name? Or is it all of the above? And the answer is all of the above. So time of entry, it needs to be military time. Medical facilities use military time. So 3 o'clock p.m. would actually be 1500, right? If you don't know how to do military time, it just starts with 1 o'clock in the morning is 0100, and you just count all the way up. 0100, 0900 is 9 o'clock in the morning. You get to noon, that's 1200. But then you just keep going. So then 1 o'clock in the afternoon is 1300, 2 o'clock is 1400, 3 o'clock is 1500, all the way up till you get up to 2400, which would be midnight. So you just count that way. So we know that 3 o'clock in the afternoon, if noon is 12 o'clock or 1200, then 1 o'clock again, I said, is 1300, 2 o'clock is 1400, 3 o'clock is 1500. So it should be noted 1500. The reason we do this is so we don't have to be confused about the PM and AM if somebody forgets to put that on there. There's no confusion about 1500. We flat out know that that is 3 o'clock in the afternoon. Nurse stating an opinion, absolutely. Patient denies pain but appears tired. Appears tired. That is an opinion. That is not a fact. That does not belong here. No line before name. When you finish your entry, now, computer charting, your name is automatically put in for you. When you handwrite entries, you put a line from the last word to your name. You put a line. That shows that you're the one that wrote that, and But again, this is only on handwritten notes. Computer, when you put a note in on the computer, your name automatically is populated. All right, Sally went into her patient's room to administer an antibiotic. Her patient states, I am not going to take another pill because they are not working. What should she do? Does she leave the pill on the bedside table and come back in a few minutes? Does she throw the pill in the trash can? Does she circle the medication on the medication record, give a reason for the refusal in the progress notes, and notify the physician? Or does she crush up the medication in the patient's food and inform the charge nurse? So the correct answer is number 3. We definitely do not leave medication in a room, ever, ever. My mother was at a rehab facility a couple years ago after a hip replacement, and the nurse came in and just put the cup of pills on the table next to my mom. Here's your pills. Well, on top of that, my mom had no water, so my mom couldn't take them. Oh yes, well, my mom called me, and y'all should know me well enough by now, hopefully, that that did not go over well. You definitely don't throw pills in the trash. And you certainly don't crush it up and put it in their medicine. When a patient refuses medication, you don't crush it up and give it to them. It's, I don't even know what term to give that. I don't know if it's malpractice or assault. I don't know what to term it. It is not, you just don't do it. Patient has a right to refuse. If they have a right to refuse medication, and you're violating their right. So the correct answer would be to circle the medication on the medication record, give the reason for it. You would circle it, say patient refused. This again is referencing back to paper charting, which I don't really think anybody does anymore, but in a paper chart, you would circle it, make your note, and then you would make a progress note. You would make a note that the patient refused. Electronic charting, you would, it's usually a drop-down box, and it says not given, and then it says why, and you have a whole bunch of choices, and one of them would be patient refused. Okay, that's the end of documentation. So if you have any questions, certainly let me know. Thank you.